So hi everybody, hope I am audible and visible. So let's start with today's topic. So today we are going to start with pediatric urology and then we will jump to something which is uh, head and neck surgery. So I will just put the PDF within 2 minutes on the group so that you can just download it on your iPads and phones. Just give me a couple of minutes. So hi everybody. So I've shared the PDF on the group as well. So before starting, you can just download it up and then we can continue. So for the timing, we are going to start off with the pediatric urology chapter, and after that we'll go down to the chapter of neurosurgery initially. So the important thing, we have already talked about undescended testes, but what you need to know is that the testes is going to descend because of the androgen derives, that is the Mullerian inhibiting factor. So the Y chromosome is going to secrete what is called as a Mullerian inhibiting factor, and Y chromosome is also going to give rise to the testes. So whenever the testes is going to be formed, the Mullerian inhibiting substance is going to be formed, and because of that the testes is going to descend. And also there is going to be a pull from the gubernaculum. There is going to be pull from the gubernaculum, and failure at any point is going to lead to something which is called as a cryptorchidism. It is going to lead to cryptorchidism. What is the Weigert-Mayer's rule? So let's consider a kidney. So whenever you are going to talk about what is called as duplication of ureter. So whenever you talk about duplication of the ureter, so there are two ureters which are going to originate from the kidney. So always remember the upper ureter is going to insert inferomedially and the lower ureter is going to insert superolaterally. So that is what you have to remember. We are going to talk about it when we are going to come to the duplication of ureter. So upper pole inserts into the inferomedial region, and often it can be ectopic near the bladder's neck. So you should remember that baby can have dribbling of urine, and that dribbling of urine is because of something which is called as Weigert-Mayer's rules of ectopic ureter. And upper pole, it is more prone for obstruction. So the upper pole ureter is more prone for obstruction and lower pole is more prone for reflux, because there is not going to be a proper mechanism. There might be urinary dribbling or there might be urinary reflux. Remember that tubularization of the urethra is going to happen in the baby, and failure of that is going to lead to something called as hypospadias or epispadias. So epispadias is associated with something called as a bladder exstrophy. So we saw something on the anterior-abdominal wall which was omphalocele. Second thing was gastrochisis. Gastrochisis is better because it is associated with no congenital anomalies, but omphalocele is associated with cardiac congenital anomalies. So the mortality is going to increase because of the cardiac congenital anomalies of the baby. And third thing which we are going to talk is the bladder exstrophy, which is going to be associated with epispadias. The sexual morphology of the child. So what I told you, sexual morphology of the child, 5-alpha reductase converts the testosterone into dihydrotestosterone, and it is going to lead the baby into a masculine character. But whenever there is going to be this hormonal deficiency, so there is going to be Y chromosome, there is going to be a testes, there is going to be Mullerian inhibiting substance. But remember, because of no testosterone, there might be ambiguous genitalia. So a baby might look something like a female, or it might also look something like XXY because of not availability of this 5-alpha reductase enzyme. We are going to again say hi to this enzyme when we are going to talk about BPH. So when we are going to talk about BPH, we are again going to check for this 5-alpha reductase enzyme. So if this enzyme is going to be deficient, the baby will not have proper masculine characters. So you should know about it. So now we are going to talk about foreskin and preputial conditions. So remember that normal prepuce of the baby is going to be non-retractile till almost 5 years of the age. So remember, the cutoff is going to be 5 years of the age and you need not do anything for it. Never go for forceful retraction. There are some pediatricians who have seen that they do something called as stretching exercises. They call the baby and they do forceful stretching of the foreskin so that they think that the adhesions won't form. So it is going to lead to more scarring of the foreskin. So never do those stretching exercises, and it can also cause something which is a medical emergency, which is a paraphimosis. So it is going to resolve naturally by 5 years of age. If it does not resolve, then you can go for circumcision. Also remember, there is a circumcision which is done mostly for some of the religious purposes. So circumcision done at birth. So circumcision done at birth is going to protect against SCC. But later on, if you are going to do it in the life, may it be 2 years or 5 years or 10 years, then the risk of SCC is going to remain normal. So SCC, the risk of squamous cell carcinoma of the penis, is going to reduce when the circumcision is done at birth and never when the circumcision is done later on. So don't have that myth in the mind that the circumcision done at any time is going to reduce. No, it is not like that. The risk of circumcision is going to, the risk of SCC is the same in a circumcised adult and a non-circumcised adult. So there is something called as a preputial pearl. So the smegma is going to deposit due to chronic urinating problems. There is a smegma which is going to be depositing, and it can lead to a non-retractile foreskin. And it is a normal finding, and you can just go for reassurance. It is going to resolve spontaneously. Again comes the true phimosis. So what is a true phimosis? Whenever there is going to be a true constriction ring of the skin. So whenever there is a true constriction ring, you can actually see that the skin is not at all going back. There is a constriction ring which is present, a fibrous ring is present. That is the time it's called as a true phimosis, and it is going to always persist beyond 5 years of age. What you can do is, you know that for fibrosis there is inflammation. For inflammation, you can stop the inflammation by applying a topical betamethasone cream for almost 2 months. So you can give a trial of betamethasone. So there might be a parent who are going to take the child to you and say that the foreskin is not being able to retract, we are not able to clean the foreskin, what should we do? And if you see that tight fibrotic skin, you can give something which is called as betamethasone cream. That betamethasone cream is going to act locally, reduce the inflammation, reduce the fibrosis, and then it can actually lead to a regression. But if not, then you need to do a circumcision. What is called as balanitis xerotica obliterans. So it is nothing but an autoimmune condition wherein there is continuous scarring of the distal urethra. So urethra is also scarred along with the foreskin. And what is the typical complaint? The stream of the urine is diverted. It is not a straight stream of the urine, and it is going to come diverted because the distal urethra is also going to be fibrosed. So here you can go for a steroid cream initially, but if the baby is not responding, then you can go for circumcision. And simultaneously, when you are going to circumcise, you can go for a urethral dilatation. So how to distinguish a normal circumcision between normal circumcision from your balanitis xerotica obliterans? There is always a problem with the stream of the urine. The stream is not proper, and that is the way you are going to differentiate between a normal phimosis and a BXO. What is recurrent balanoposthitis? So due to recurrent infections and non-retractile foreskin, there is going to be what is called as chronic inflammation and scarring. So what happens whenever the patient is going to come with redness, swelling and inflammation, you are going to give what is called as conservative management initially. So many times you get a call from medicine ward, a typical young diabetic male, so a type 1 diabetic male who has developed balanoposthitis. So he had a previous episode, given antibiotics, went home, now again admitted for high insulin levels, high sugar levels. The patient is on insulin, and now they have given you a call for recurrent balanoposthitis. What is to be done? Baby, the boy is 10 years of age. What is to be done? So don't do anything right now. Conserve the child and call him after 4 weeks for elective circumcision. So if it is more frequently seen, typically it is seen in immunocompromised patients like diabetes. Because of diabetes, there are recurrent infections. So you can go for circumcision after 3 years. So the only indication of circumcision in a child is balanoposthitis. Rest all, you are going to defer the child for 5 years of age. And by BXO, it is in dermatological textbooks, it is now stated as lichen sclerosis, and it is the most common pathological phimosis beyond 5 years of the age, and distinguish the physiological phimosis from it in infants. So don't go in the haste and operate the baby child. It can lead to tremendous complications later on. Something called as a Vesicoureteric reflux, very common question in NEET PG, always asked. So what is VUR? So because you know that whenever the ureter is going to go inside the bladder, so this is going to be the bladder wall, and ureter is going to come here. Naturally what happens is, initially the ureter is directly opening into the bladder wall, but later on there is formation of the tunnel and the ureter gets an angle. So when the bladder contracts, that tunnel is going to compress the ureter and the urine is not going to reflux back into the ureter. So that is the normal mechanism wherein the ureters are not filled with the urine during micturition. So that is what is called as reflux mechanism, which is prevented in a normal adult. But in a child, there might be vesicoureteric reflux because of non-development of the ureteric channel. So if the ureteric channel is not properly developed, there is going to be some reflux. So how are you going to see the reflux? You are going to do an investigation which is called as MCU, micturating cystourethrogram. So you are going to inject the dye in the bladder and ask the child to void the urine, and you are going to click the X-ray. So in X-ray, you can see 5 grades of the VUR. So in grade 1, there is only filling of the ureter. In grade 2, there is filling till the kidneys. So it is filling till the calyces. In grade 3, there is going to be some dilatation. There is going to be some dilatation of the calyces and the ureter. So grade 3, there is going to be dilatation. In grade 4, there is going to be some tortuosity. And there is going to be loss of the calyceal system. And in grade 5, there is going to be lot of tortuous ureter. So it is a, if we are going to come back to grade 4 and grade 5, it might land up into medical emergency because the child might develop pyelonephritis. So it is very important for you to make sure that you are going to diagnose this condition on the time. So grade 1 is reflux into ureter, grade 2 is reflux into the kidneys, grade 3 is mild to moderate dilatation, grade 4 is moderate dilatation with ureteral tortuosity, and grade 5 is gross reflux. And in grade 5, you are going to go for surgical reimplantation. Surgical reimplantation of the ureter with creation of the new valve is the surgery of choice. In grade 1, grade 2 and grade 3, you have to give antibiotics. Why? Because what happens is, because of the chronic reflux, there might be infection setting in, and that infection can lead to life-threatening pyelonephritis. So prophylactic antibiotics is to be given for all the children because to prevent the further complications. Along with that, very important thing, it is the toilet training. So what do you do? Instead of filling the bladder totally until the child has the urge to micturate, ask him to void the urine after every 1 to 2 hours. So what is going to happen? The bladder is not going to distend much, and because of that, the reflux is going to be low. So you have to give what is called as a toilet training. Toilet training. And in 4th stage, what you can do is you can give what is called as a sting procedure. So what do? They are going to go cystoscopically. And here they can inject some amount of Teflon or silicone. So when you are going to inject some amount of Teflon or silicone, it is going to act for a temporary valve measure. So what happens is, when the child is going to grow, that valve is going to develop naturally. But till the valve is not developed, you can go for a Teflon injection in the near the uretrovesical junction. So whenever you are going to inject that valve, it is going to prevent the reflux into the ureters. So that can be done for grade 4. So grade 1, grade 2, grade 3, you are going to manage conservatively with toilet training and antibiotics. Grade 4 and grade 5, you are going to go for surgery. Grade 5, reimplantation. Grade 4, you can go for endoscopic sting procedure. So sting procedure is an important MCQ here, and which should be known for you, and you should just make sure that you don't miss it out because it is frequently asked in the NEET exam. So what is the sting procedure? Suburethral Teflon injection. And it is a day case procedure, and almost it has 70 to 80% success rates in grade 3, grade 4 VUR. So you should weigh the benefits and risks while doing the procedure. So if you think that a 3rd grade child, I don't mean to say 3rd grade to the child, but when a child is having grade 3 vesicoureteric reflux, and you feel that the child might get recurrent UTIs, the child is not getting trained properly, so you can go for sting procedure even in grade 3. So it is justified. But when it comes in paper, grade 1, grade 2, grade 3 conservative management, grade 4 sting procedure, grade 5 you are going to go for ureteric reimplantation. So then when comes the duplication of the ureter. So when there is a duplication of the ureter, always remember what is a very take home point and MCQ, that is the Weigert-Mayer's rule. So what is going to happen? The upper pole is going to insert in the lower part, and it is going to be medially. So upper ureter inferomedially, and the below part of the ureter, the second ureter is going to insert superolaterally. So upper pole goes below and lower pole goes above. So it is important to know. So as rightly shown in the diagram, it is shown here. And the lower pole, because there is not development of proper sphincter, it is more prone for vesicoureteric reflux. So it is again a take home point. You should know about it. So upper pole ureter inferomedially, and it might go into hydronephrosis, because here it is going to insert more superiorly. It can undergo obstruction, hence there might be hydroureter hydronephrosis in the superior pole, and in the inferior pole, because there is loss of valves, there might be reflux. So reflux in the inferior ureter and obstruction in the superior ureter. So VUR, it can lead to vesicoureteric reflux, can lead to chronic obstruction, it can lead to pyelonephritis, and can lead to renal scarring. So it is very much important. Now coming to something which is called as posterior urethral valves. So posterior urethral valves exclusively seen in males. Exclusively seen in males. What happens is there is going to be a one-way valve. So this is going to be your bladder, this is going to be your bladder, this is going to be your bladder neck. So there is going to be a one-way valve. So this one-way valve is acting like this. So whenever you are going to put a Foley's catheter, it is going to go inside. But this valve, whenever the urine is voiding from the bladder, this valve is going to prevent the reflux. This valve is going to prevent the urine coming down into the urethra. So it is a one-way valve which is called as a posterior urethral valve, typically seen in the child. So what can you see? It occurs typically in the males only, and it folds, the urethra folds posteriorly and obstructs the urine flow. So when you are going to study urology in detail, there are three types of posterior urethral valves. Type 1, type 2, type 3, most common being type 1. Again, as we told you, that whenever you are in fix, just go for type 1. Whenever you don't know what is the most common type, go for type 1. But here, what is going to happen? Because the urine is not going to be generated by the baby, the urine is going to get stored in the bladder, and we know that amniotic cavity, the amniotic fluid is formed by the fetal urine. So urine is not going to be secreted, hence there might be bilateral hydronephrosis plus thick walled bladder on ultrasound along with oligohydroamnios. So oligohydroamnios may be there in the baby. Diagnosis is again MCU is to be done. It shows characteristic posterior urethral dilatation, and management is fulguration. So take the baby inside the OT and just fulgurate the valve. So if you are going to fulgurate the valve, the urinary tract is going to be patent. But remember, if you are not going to treat in the time, the baby can end up in chronic obstruction and retention, and it might lead to bladder dysfunction. The bladder muscle might go necrosis later on, and the child might develop atonic bladder. So always remember, after fulgurating, the nephrology follow-up is very much essential. So we told about two scans. What are the two scans? DMSA and DTPA. So we talk about DTPA being a functional imaging and DMSA S for scarring. Sometimes what happens is DTPA cannot be done because it is actively secreted. So here that's what they have said, that whenever you think that the patient is having some glomerular dysfunction, whenever the creat of the patient is going to be high, whenever you think that the patient is in AKI, you cannot do something which is called as a DTPA scan because the DTPA is excreted from the glomerulus. So what do? You do a MAC3 scan. So MAC3 scan is where the tubules are going to secrete the MAC3. So MAC3 is always done in the patients who are having stable renal function. So hence it is preferred over DTPA in children because children might have impaired renal function. So for functioning, two scans, DTPA and MAC3. And for scarring, it is S for S, DMSA scan. So you should know 3 scans of the nuclear imaging of the kidneys. Now coming to the congenital PUJ obstruction. It is because of some defect at the congenital pelvic-ureteric junction. So it is some defect at the congenital pelvic-ureteric junction, and because of that there is dilatation of the pelvic calyceal system only. So this is your kidney. So let's consider this is the kidney. So this is the place where there is going to be obstruction, and because of that there is going to be upstream dilatation of the pelvic calyceal system. So you have to make sure that how much amount of obstruction is present. If the obstruction is very much large or more, that is the time you should go for a surgery. So it is because of some collagen or muscle abnormality at the pelvic-ureteric junction. Especially what happens is patient will have intermittent loin pain because when the baby is going to have a lot of water, the kidney is going to suddenly swell up and it might cause intermittent stretch of the renal capsule. Hence intermittent loin pain after drinking a lot of water is a pathognomonic feature. It is there might be finding of an incidental hydronephrosis when you are going to do USG of the baby. Again, as I said, we don't know the function of the kidney, so you can go for USS with MAC3 scan. And always remember that if the dye is going to be retained for more than 20 minutes in the kidney, if the MAC3 dye in kidney for more than 20 minutes, that is the time you are going to suspect that the baby is having some obstructive features. Management is pyeloplasty. So always the management is going to be pyeloplasty. So you are going to reconstruct this ureter. So you are going to remove this segment. You are going to remove this segment and you are going to anastomose it with the normal ureter. So similarly what we were doing in the Hirschsprung's disease. So similarly what we saw in the colon in the form of Hirschsprung disease, similarly it is seen something in the ureter. Asymptomatic, you can go for observation. So there was a patient who had presented to the OPD and he was actually having PUJ obstruction since birth. So at the age of 65, a urologist told him that you should operate. So always remember, any benign disorder which a patient might have since birth, so unless it is troubling the patient, you should not operate. If 70 years the patient is living with the disease and he did not have any problem, what else is the patient going to have in the next 3 to 4 years? So always remember, any patient with any benign etiology since childhood, patient is living normally with no complications, you can straight away conserve the patient without giving any second thought. So mild to moderate, you should conserve the patient. If the patient is asymptomatic, you can conserve him. It may resolve spontaneously later on in life. Hypospadias, urethral meatus opens on the ventral surface. We all know that this is going to be the penis. This is going to be the penis, this is the penis, this is the foreskin. So whenever the opening is located somewhere below the penis, so that is actually called as a ventral surface. So whenever the opening is present, it is called as hypospadias. And always remember, hypospadias is again repaired by the time of 6 to 8 months. We saw that undescended testes 6 months, bilateral always at the 6 months, hydrocele you can wait till 2 years, congenital hernia around 6 months to 18 months you can wait. Same way for hypospadias and epispadias, you can wait for 6 months to 18 months. Epispadias, urethral meatus opens on the dorsal surface. So epispadias is nothing but the urethral surface is going to open here somewhere on the dorsal surface. It is going to be associated with bladder exstrophy, and here you can go for a staged repair. So always remember, any urethral surgery should be undertaken by an experienced urologist, because the first surgery is always considered to be the best surgery. Any urethral surgery, the first surgery is the best surgery. So it should be done at a tertiary center wherein proper urological training is there and proper urologists are functioning. It should not be taken up by anybody who is doing it for the first time. Why? Because if the urethra gets scarred, then later on the addition of more surgeries is going to cause a lot of problem. So the first surgery is the best surgery, is what the dictum you should remember when you are dealing with the urethra. Urolithiasis in children. So again, always ultrasonography is preferred when the child is having kidney stone. Never you are going to go for a CT scan, because we know that CT scan is going to cause, CT scan is going to cause lot of radiations. And always remember, ESWL can be used till, it is a shockwave lithotripsy, can be used till 2 centimeters, and RIRS. So nowadays what they do, they can actually go till the kidneys via the ureters. So through the ureters they can go till the kidneys, so that is called as RIRS. So they can go till the kidneys from the ureter with that flexible scope, that is called as RIRS, retrograde intrarenal surgery, and it is generally avoided in the children due to smaller ureter caliber. So in children you are not going to do RIRS. In adults, RIRS is going to be the gold standard these days. And always remember, 24 hours urine for calcium, uric acid is always to be done, because in child, if the child is having some stones in the kidney or in the ureter, some metabolic abnormality might be present. So always think about some metabolic abnormality being present, and always do a metabolic workup. Always check for calcium, oxalate, uric acid, parathyroid levels in the child, because we need to know if there is some pathology going on in the child. So it is always important. So there is one factual thing while going Mittendorf's procedure. So it is when we are going to do a bladder augmentation or reconstruction in a child with neuropathic bladder. So you can do a bladder augmentation with colon or with ileum. So that surgery is very much important. Principle is appendix can be used to self-catheterize. So whenever you are going to create a new bladder, you need to actually make an orifice to it. So that orifice, you can use appendix as the orifice between the bladder and the umbilicus. But if appendix is to be removed, if there is an inflamed appendix, you can use a part of the ileum and you can tubularize it. So it is nothing but a Mitrofanoff's procedure. So Mitrofanoff's procedure is nothing but it is used for augmentation of the bladder in patients with congenital atony of the bladder or congenital hypoplasia of the bladder. So whenever the bladder is not functional, you can go for augmentation of the bladder with either ileum or colon, and appendix is used as the urethral opening. So it is called as Mitrofanoff's procedure. Alternative channel, if appendix is unavailable, ileal segment can be done. So it is called as a Monti's procedure. Name are not important, might be asked, might not be asked again, but you should know the concept, what is to be done. So it is very much important. So here we come down to the end of what is called as the urosurgery chapter in pediatrics. Now we are going down to very interesting chapter, which is neurosurgery. So here in neurosurgery, we are going to deal with many facts which a neurosurgeon encounters. It might be because of trauma, it might be because of tumor, but you should know basics of everything. I don't expect, or nobody expects you to know the all the chapters and everything from neurosurgery, but basics is what everybody is asking you. So always remember, as we talked about the brain injury, we talked about primary brain injury and secondary brain injury. So primary brain injury is because of the impact. So whatever the trauma is going to be to the brain, that is going to lead to primary brain injury. But secondary brain injury is because of raised ICP. So what is the typical physiological feature of raised ICP. So normally when the ICP is more than 20 mm of mercury, whenever the ICP intracranial pressure is more than 20 millimeters of mercury, it is termed to be raised ICP. So there are two types of headaches, a high pressure headache and a low pressure headache. So high pressure headache is when actually the ICP is raised. So what happens whenever you are coughing, whenever you are doing Valsalva maneuver, whenever you are bending forward, naturally there is going to be pressure inside the cranial cavity and it is going to be worsening on coughing and Valsalva, and you can see a papilla edema and it is associated with projectile vomiting. Projectile vomiting. It can be because of any cause. It can be because of tumor. It can be because of trauma. It can be because of infarct. And here it is very much urgent. If the ICP is raised and papilla edema can progress to permanent blindness. So any patient who is presenting to you with features of raised intracranial pressure, it needs to be monitored. It needs to be actually taken down. So how to take down, we have already seen in the neurosurgery chapter. Proper position for the patient. You are going to go for permissive hyperventilation for the patient. Give mannitol, give 3% NS to the patient. You can actually go for extraventricular drainage. You can go for decompression craniotomy. So whatever. So we have seen the modalities in the neurosurgery chapter. Here what we are seeing is, yes, whenever the pressure is going to rise, I need to manage it as soon as possible. Urgent emergency. Sir, what is a low pressure headache? So low pressure headache is when the pressure is going to be low. When does it happen? Sir, whenever you are giving a spinal anesthesia. So after giving a spinal anesthesia, you withdraw the needle. Most of the times there is some trauma caused to the dura mater. There is some trauma caused, and because of that, continuously there is dribbling of some amount of CSF near the back. Because of that, the ICP level is going to reduce, and when the intracranial pressure is going to reduce, the patient is going to have headache. But typically when the patient stands, we know that brain is floating in the CSF. So whenever the CSF is low, the brain is going to sink down, and because of that, the patient is going to have headache, and typically it is seen worst on standing. And when the patient is going to sleep, it is going to relieve. So it is very much important. It is post-lumbar puncture, or there might be some CSF leak. Whenever there is trauma, there might be CSF rhinorrhea, there might be CSF otorrhea. So that is the time the patient is going to have low pressure headaches, and it has to be managed conservatively. How do you manage a PDPH? So whenever there is a post-dural puncture headache, what is the mechanism? Why is the headache going to be present? So when you are going to talk in simple terms, what is going to happen? Let's discuss. So what happens is, we know that in brain there are 4 components. So what are the 4 components? One is the artery, one is the vein, one is the CSF, and other is going to be the brain. So naturally when the CSF is leaking, so CSF when the pressure is going to reduce, what is going to happen? Compensatory mechanisms are going to be taken up by the arterial and venous system. So because of that, the arterial pressures are going to rise, the venous pressures are going to rise, and because of these venous pressures and arterial pressure rising, there is going to be something which is called as, yes, PDPH, post dural puncture headache. Then how are we going to manage it? We are going to give coffee. So what does caffeine do? Caffeine does vasoconstriction, same which we are going to do in migraine. In migraine, there is going to be vasodilatation of the intracerebral blood vessels, and because of that, there is going to be pain. So whenever we are going to give coffee, it is going to cause vasoconstriction. So it is very much important for you to know that what is the mechanism of PDPH, or what is the mechanism of low cerebral pressure headache. So it is nothing but raised ICP. It is because of the dilatation of the blood vessel. Sorry. What is thunderclap headache? So whenever there is sudden and maximal onset of headache, the patient is going to tell you that असं डोकं कधीच दुखलं नाही, ऐसा सरदर्द मुझे कभी भी नहीं हुआ. So worst headache of the life, always think about SAH. Subarachnoid hemorrhage is until otherwise proved. So very much important to know. And again, emergency CT scan is required, and you should manage the patient stat. Whatever is going to come down in the CT scan, manage the patient accordingly. Raised ICP is a neurosurgical emergency. Without urgent management, it leads to cerebral herniation. So what is going to happen? We know that there are brain cavities. So we know that there is in the posterior cranial fossa. This is the brain. This is the posterior cranial fossa. Here there is going to be cerebellum. Here there is going to be cerebrum. So this cerebrum will come down into cerebellum because of the raised intracranial pressure. This cerebrum will go into the posterior cranial fossa in the cerebellum. This cerebellum might herniate into what is called as the foramina magnum, and it might lead to cerebellar tonsil herniation and can cause sudden rise in ICP, and the patient might go in what is called as coning. Sir, how to know if the patient's brain is herniated clinically? So you know that when the cerebrum is going to come down, the cerebrum is going to push the midbrain. And we know that in midbrain there is the third nerve nucleus. So whenever the pupils are not reactive to light, whenever there is ipsilateral pupil damage, or whenever one side of the pupil is not reacting to light, the first thing you can think about is the cerebral tonsil herniation. So raised ICP, cerebral herniation, it is causing pressure on the third nerve. And whenever the pressure is coming down from the cerebellar tonsil, when the cerebellum is going to come down from the posterior cranial fossa, what is going to happen? The cerebellar, when it is going to come down from the posterior cranial fossa, there is going to be what is called as bradycardia with hypertension. That is called as, yes, that is called as Cushing's reflex. It is going to compress the medulla. So whenever the medulla is going to be compressed, it is going to cause hypertension with bradycardia. And also it might lead to problem with respiration. So whenever there is going to be tonsillar herniation of cerebellum, so but clinically you should know that there might be some herniation. So I've given you two tricks to know. Whenever there is cerebral herniation, there is going to be third nerve nuclear palsy. But whenever there is going to be a cerebellar herniation, that cerebellar herniation is actually going to give rise to what is called as Cushing's reflex, which is a hypotension and bradycardia. So how are you going to check for the ICP? So here you can check a photo which has been given. So this is called as an ICP transducer. So this is called as an ICP, intraparenchymal monitoring transducer. So it is like a needle you are going to inject inside the brain, and you are going to connect it with a transducer, and it is going to tell you about the ICP. So it is nothing but we are going to monitor the raised ICP. So how is the ICP waveform checked? So whenever you are monitoring the ICP, the waveform can be checked on the transducer. So there are three waves which are seen. So you can see the waveform here. So this is the normal waveform. The P1 waveform is because of arterial pulsations. The arterial pulsations are going to give rise to the P1 waveform. The P2 waveform is going to be the reflection of that arterial pulsations from the brain. So P2 is going to dictate about the brain parenchyma. And we know that there is going to be closure of the aortic valve, and that aortic valve also causes the changes in the JVP and our pulse. So that pulse is going to be reflected by the aortic notch. So these are the three waves which are going to be seen. But whenever there is going to be raised intracranial pressure because of something, the brain compliance is going to reduce. The brain is not that elastic anymore because of the raised ICP, and because of that the waveform is going to change. So the normal waveform 1 greater than 2 greater than 3 is going to become 1 less than 2, and then it is going to be greater than 3. So this waveform is typically seen in the raised intracranial pressure. So whenever ICP transducer is attached and you are seeing this in the monitor, just make sure that you have seen it very much and you know that what type of waveform it is. So it is very much for you to know. So I hope it is clear. I hope it is clear to you, and then we will proceed. So what happens is ICP monitoring, you can put on an intraparenchymal catheter or intraventricular catheter. So we will talk about intraventricular catheter in just 2 minutes. Waveform, P1 is the percussion wave because of artery, P2 is the tidal wave because of brain compliance, and P3 is because of the aortic valve closure. So always remember, when P2 greater than P1, it indicates that the compliance is reduced and brain is approaching the exhaustion of the mechanisms. So when the P2 goes beyond a certain threshold, the neurosurgeon is going to decide whether to do a surgical intervention to the patient or not. You can conserve till the P2 is going to rise. So if anybody wants to take neurosurgery, always remember that you should have these all devices in the hospital, and then only go to that institute for doing your super specialty. Why? Because all these things are going to be tertiary care, and all these things are required in your day-to-day practice. So when to operate, when not to operate, it's not just based on the clinical and imaging findings. These things are required. That is why there is a separate neurological ICU in all the big hospitals. This is what is very important for you to know. So as a surgeon, if you are visiting any neurological ICU, you should know that what are the waveforms, what is a P1 and what is a P2, when is P1 important, when is P2 important. These all things are very much important. P1 is dampened in traumatic brain injury. It indicates disruption of the arterial transmission. So any bleeding is going to happen, the P1 is going to be disrupted. We know normal ICP is less than 15 and less than 7 mm in children. Raised ICP, so whenever it is more than 20 to 25, it is considered to be very emergency and warrants treatment. So this waveform is very much for you to know. Now coming down to what is called as hydrocephalus. What is hydrocephalus? So whenever the ICP is going to rise because of some CSF pathology, it is called as hydrocephalus. In children, the head is going to get large, the ventricles are going to dilate. But in adults, even if this is not happening, even if the skull is closed, the ventricles are going to dilate in the CT scan, and the brain parenchyma is going to be compressed. So it is called as hydrocephalus. So how are you going to classify the hydrocephalus? First is the obstructive and other is the communicative. What is obstructive and what is communicative? When you are going to check for the CSF flow, We all know that the CSF is formed in the lateral ventricles. In the lateral ventricles, the CSF is going to be formed. These are the lateral ventricles. From the lateral ventricles, it is going to go into the third ventricle, and the third ventricle is going to open into called as fourth ventricle. And there are two foramens, the foramen of Magendie and foramen of Luschka, which are going to connect to the subarachnoid space. So whenever the fluid is freely flowing, when it is entering the subarachnoid space easily, there is no problem with entering into the subarachnoid space. It is considered to be a non-obstructing. But whenever there is some obstruction, let's consider there is a tumor here. When the aqueduct is going to undergo stenosis, the actual CSF cannot come down into the foramen of Luschka and Magendie, and they cannot enter the normal subarachnoid space. So that is the time you are going to call it as an obstructive hydrocephalus. So now we are going to talk about the causes of them. So what is obstructive cause? It is the blockage within the ventricular system before entering the subarachnoid space. Very much important. It might be because of aqueductal stenosis in the childhood, some tumor, or because of some bleeding, there might be some clot which can be seen, or there might be some tumor like glioma. And ventricles do not communicate with the subarachnoid space, so it is very much important, and hence it is called as obstructive hydrocephalus. In communicating hydrocephalus, the CSF absorption is failed at the arachnoid granulations. So when we know that when the CSF is going to enter the subarachnoid space, there are going to be small granulations in the brain. So there is some small granulations in the brain from where the CSF is going to be absorbed. So if there is some infection, there is some meningitis, there is some tuberculosis, these pores are going to be blocked. So when these pores are going to be blocked, there is going to be blockage of absorption. So this is going to be pathophysiology of non-communicating hydrocephalus. So it is seen most commonly post meningitis, post hemorrhage, because the hemorrhage there is clot formation, or there might be some venous thrombosis in the brain. The ventricles communicate freely with the subarachnoid space. So that is the take home point from this point. Now there is a rare condition wherein actually the CSF production is increased. Where do you see? When you know that the CSF is secreted from the choroid plexus. So whenever there is going to be a choroid plexus tumor like papilloma or carcinoma, excess CSF is going to be secreted, and that excess CSF is going to cause hydrocephalus. So it is very much important because there is some overproduction. But it is a very rare cause, and excess CSF is produced, and again it is a communicating type. And what is a normal pressure hydrocephalus? So because of some conditions in genetic mutations, or let's consider some like the actual etiology is not known, what happens is the brain, the actual property of the brain distensibility or the brain compliance is reduced in a patient. So when the compliance is reduced, naturally the CSF is not that much competent to hold a larger compliant brain. So because of that, the pressure seems to be high. But when you are going to do a transdural catheter, you can see that everything is normal. Or if you are going to do a lumbar puncture, the pressure is going to be normal. So it is called as normal pressure hydrocephalus. On a CT scan, the ventricles are dilated, but when you are going to check for the lumbar puncture, everything is going to be normal, and it is going to damage all the areas near the ventricle, and it is going to cause what is called as three typical signs. So it is called as urinary incontinence, which develops first, then comes the gait atraxia because of the cerebellar problems, and then comes the cognitive impairment because these lateral ventricles are then going to compress the cognitive region. So three things which are important if you want to remember: wet, wobbly, and wacky. So wacky means he cannot speak properly, wet means he cannot maintain the urinary continence properly, and wobbly means he cannot walk properly. So typical triad of normal pressure hydrocephalus, it is nothing but wet, wobbly, and wacky. So this can also be considered as dementia. Cognitive impairment, he is not able to recall, it is also called as dementia in certain books. So it might be urinary incontinence, gait problems, and cognitive impairment. So it is the normal pressure hydrocephalus triad. The brain has impaired elasticity, and the pressure transiently rises and then normalizes. So whenever you are going to check for the pressure, it might surprisingly seem to be normal. So it is very much important. It is seen in elderly or post-SH or post-meningitis, and it is again a communicating type. So because there is a problem with the brain, it is going to be a communicating type. Now coming down to one condition, which is idiopathic intracranial hypertension. We have ruled out everything. There is no tumor, there is no meningitis, there is no clot, there is no normal pressure hydrocephalus. Then what is the cause? So no underlying cause, but there is ICH. So there is intracranial hypertension without any cause. So it is a rare variety. I am teaching you this because it might come in neurology, it might come in pediatrics, it might come in other specialties. But as a surgeon, you should be knowing these disorders because you should know when to intervene the patient and when should not. You might not be able to do a burr hole, you might not go for a craniotomy, but you should, as a doctor, be knowing that yes, this needs intervention, this does not need intervention. So that is why we are trying to study this. So there is no structural lesion, pressures are more than 25. We saw that the pressure, if more than 20 to 25, it is considered to be raised ICP. Young obese female also associated with some tetracycline or vitamin E excess or steroid withdrawal. We have seen, where do we give vitamin E? We saw that we give him hydrocephalus suppurativa. So if you have seen that condition in the dermatological chapter, we have seen in the plastic surgery. So we saw that we give retinoids to the patient. So that retinoids can actually cause what is called as idiopathic intracranial hypertension. Presentage is high pressure headache pattern, and there might be pulsatile tinnitus because the vessels are constantly beating up. There is some tinnitus. The CSF floats and the nerve is going to cause repeated stimulation, and you can have tinnitus, and there might be some visual field loss. Because of the raised ICP, there is papilledema and there is a visual field loss. Remember that here we need to drain the CSF, and for draining you can go for acetazolamide. You know that it is a carbonic anhydrase inhibitor. It is a diuretic which is a carbonic anhydrase inhibitor, and it is going to reduce the CSF production, and it will also cause some amount of weight loss to the patient. And if the patient is having some eye problem, now you cannot do anything for it because there is no cause. You cannot find any cause why the ICP is raised. So what you can do, you can go for optic nerve fenestration. So do you know that this is the optic nerve? If this is the optic nerve, what you can do is you can drill the optic nerve at multiple places so that the CSF leaks out from the optic nerve. So the CSF, if it is going to leak out from the optic nerve, it is going to go for, yes, you can actually go for relief of the optic pressure, or you can go for what is called as intermittent shunting. So you call the patient once in a week, you do some lumbar puncture, send the patient home. So you can do this for some time, but it is again going to be a temporary relief. So optic nerve fenestration operation can be done. So it is very much important to know optic nerve fenestration can be done in procedures dash 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 dash. So you should know that it is done ideally in idiopathic intracranial hypertension. So how are you going to divert the CSF? So as I told you, if the pressure is high and if all the ICP managements are failed, we say that we saw every procedure in the neurosurgery module. What is the next line of management? How are you going to drain the CSF? So for draining the CSF, what you can do is an extraventricular drain. So for draining the CSF, what you can do? For draining the CSF, you can put what is called as an extraventricular drain. So when there is an acute hydrocephalus in the child and you require ICP monitoring, when there is an hemorrhagic CSF diversion, you should go for what is called as external ventricular drain. How do you put an external ventricular drain? So a point is going to come which is going to be a Cocker's point. So what is a Cocker's point? So there are many things which are related to Cocker in general surgery, but what is a Cocker's point? It is 2.5 centimeter lateral to midline and 1 centimeter anterior to the coronal suture, and you are going to point it towards the ipsilateral medial canthus. So if you are going on the right side decompression or right side intraventricular drain, external ventricular drain insertion, you need to point down to the right medial canthus of the eye, where just 2 centimeter lateral to the midline and 2 centimeter anterior to the coronal suture, and you are going to straight away go on drilling, and you are going to go into the ventricles. So that is called as a Cocker's point, which is very important question, expected questions in your exams. But what happens is, because you are going to go from the external surface, the infection might go there and there might be chances of ventriculitis, and ventriculitis is really bad. Ventriculitis causes 80% mortality. So always remember that it is a very dangerous procedure when you are going to go for EVD, external ventricular drainage. So nowadays what they do is internal ventricular drain. We are going to talk soon about it. So if you can see that this is the Cocker's point, this is the midline, this is the midline, this is the Cocker's point, and if you can see that it comes in the mid pupillary line, just 2 centimeter lateral. So here you can see again a diagram of 2 centimeter lateral, and it is going to be 1 centimeter anterior. So this is the coronal suture. So 1 centimeter anterior to the coronal suture and 2 centimeter lateral. So this is the exact point which is called as a Cocker's point, and you are going to put the drill in the direction of the medial canthus of the eye. So right side, right medial canthus. So you are going to insert the drain in this fashion. So you are going to insert the drain in this fashion, and it is go directly into the ventricles. So you can see that the ventricles, the drain is placed inside the ventricles directly. You can see that the ventricle, see, it is the same thing. Here they have inserted the drain. So you should know about it very much when you are thinking about external ventricular drainage. Now coming down to what is called as a VP shunt. So what is a VP shunt? So whenever you are going to require a long-term drainage, so when it is a short-term acute condition for trauma, when you are going to go for some like just procedure for maybe 2 days or 3 days of drainage is required, you can go for an EVD. But whenever you want to go for a long-term drainage procedure, then you should go for what is called as a ventriculoperitoneal shunt. The drain, the CSF is actually drained into the peritoneum. It is a gold standard. It is a gold standard. It might be also inserted into the pleura or in the atrium. So it can be a ventricular pleural or ventriculoatrial shunt. But here also there might be over drainage. So there is a transducer. There is a small transducer which is going to divert the pressure. So there are different types of there are different types of VP shunts available, and there is a pressure mechanism in them. So there is set amount of pressure. So whenever the pressure in the CSF is going to rise about that, then only the drainage system is going to start. So there are low pressure systems, medium pressure systems, and high pressure systems. So you should know which type of pressure systems is to be used in which type of children or which type of adults. Lumbar drain, again you can put a lumbar drain. It can be communicating hydrocephalus. So always remember that when it is a communicating hydrocephalus, then only you can put a lumbar drain. If it is a non-communicating hydrocephalus, we already saw in the diagram that the problem is going to be somewhere here. So if you are going to drain from the lumbar puncture, what is going to happen? The lumbar fluid is going to come out, and the fluid is not able to come down here. So the spinal cord will go into the dry state, and the spinal cord might go for a toss. So always remember that when it is an obstructive hydrocephalus, never you are going to go for lumbar puncture. Obstructive hydrocephalus, lumbar puncture contraindicated. But if it is a communicating hydrocephalus, you can straight away go for a lumbar drain. What is third ventricular endoscopic third ventriculostomy? So what happens in endoscopic third ventriculostomy? So you know that this drain is a foreign body, so it can be kept for certain period of time, but after some time, that even the drain might get blocked up, there might be meningitis, there might be drain related infections, sepsis, meningitis, and the patient might land up into death. So permanent solution, what they have found out is a third ventricular endoscopic third ventriculostomy. So what you are going to do, so we know that this is the third ventricle. So this is the third ventricle. So what do? You are going to drill near the base of the third ventricle, and here you can hit what is called as a cistern. So whenever you are going to hit that region, the cistern is going to open up, and all the fluid is going to start draining into the third ventricular base. So typically it is seen in obstructive hydrocephalus, wherein there is no communication with the spinal cord. There is some amount of obstruction which might be present in this region. So what do? You can straight away go for an endoscopic third ventriculostomy. So what is going to happen? All the CSF is going to drain into those cisterns, and automatically the pressure is going to reduce. So you can go it endoscopically. Again, we know the point, it is going to be the Cocker's point. So very much important, Cocker's point in neurosurgery, very much important point. There is a Viva question, they ask, name all the different types of Cockers in surgery. So Cocker's forceps, Cocker's incision, Cocker's thyroid forceps, then Cocker's point, what is Cocker's sign, Cockerization of the duodenum. So everything related to Cocker you should be able to tell. There is a even short note right about the Theos Cocker. So the Cocker was a surgeon who actually was doing good amount of surgery. Thyroid was his specialty. He even received a Nobel Prize. So you should know all about him. But when Cockers comes, you should know that what type of Cockers are present in surgery. Now we are going to shortly talk about the intracranial infections. So what are the intracranial infections you are going to come across? So there is something called as a bacterial meningitis. So meningitis, the triad, we know that the patient will have photophobia with neck stiffness, with fever and headache. So headache, photophobia, neck stiffness, typically of it is the meningitis, and we know that there is Kernigh's or Brudzinski sign, and it can progress to encephalopathy and death. So if anybody is active on the chat, I would like to know what is the Kernigh's sign and what is the Brudzinski sign. CT is the first investigation of choice, and it will CT is the first investigation of choice, and then you should actually do a lumbar puncture. So lumbar puncture is going to tell about the cloudy CSF. Always remember lumbar puncture, then followed by prophylactic antibiotics, never the vice versa. Never give an antibiotic and then do the lumbar puncture. Lumbar puncture will always come negative. So first do a lumbar puncture. Whenever a patient of meningitis comes, first post him for a lumbar puncture. As soon as lumbar puncture is done, given antibiotics. So empirical antibiotics, do not wait for a lumbar puncture, is what is given in surgical textbooks. But if you are going to go according to Harrison, always and always you are going to do a lumbar puncture first, and then you are going to follow it with antibiotics. But if it is an emergency, obviously you don't have that much amount of time, so antibiotics might be given. Ciftriaxone is given, and dexamethasone is given for reducing the cerebral edema. And post-traumatic, if the patient is having post-traumatic meningitis, always remember to add gram negatives. Normally it is gram positive, but if it might be because of any trauma, there might be some anaerobic coverage required, so that time you can add a coverage of gram negatives and anaerobes. What is a brain abscess? So it is a triad of fever, headache and focal neurological deficit. So in meningitis, no focal neurological deficit, there is neck stiffness, but whenever it is fever, headache, photophobia along with some neurological deficit, it might be related to brain abscess. Always remember one dictum, brain abscess can be confused with what is called as glioma. So grade 4 glioma is always confused with brain abscess. So how are you going to differentiate brain abscess and glioma? So you are going to do what is called as diffusion weighted MRI. So diffusion weighted MRI. So whenever you are going to do a CT scan, you are going to be confused between whether it is going to be an abscess or whether it is a glioma. So whenever you are confusion, you are going to go for diffuse weighted MRI, restricted diffusion. So always remember that restricted diffusion is always present. When the restricted diffusion is always present, then it is going to tell about the glioma. So diffusion restriction MRI is done, and always remember for abscess, emergency surgery is required. Aspiration or excision of the abscess is done, so that abscess cavity is removed, and prophylactic and the prolonged antibiotics are given for 6 to 8 weeks. And remember that if it is not treated in time, the mortality can go up to 100%, and if it is treated on time, the mortality reduces to 4%. And we talked that ventriculitis, the inflammation of the ventricular endothelium, is very risky. The ependymocytes in the ventricle, if they are going to get inflamed, the mortality is going to straight away jump from everything to 80%. So ventriculitis is always going to be life threatening. Subdural empyema. So because the bleeding, if the SDH is not drained properly, there might be some infection setting, or if there is some fracture, that fracture might become infected and it might lead to some post SDH subdural empyema. It is rapidly progressive. Again, it is like a brain abscess, but it is not situated intraparenchymally. It is situated extraparenchymally. So it is SDH. So it is like a subdural empyema. CT and MRI will going to give about the crescent collection. We have already seen how the CT and MRI looks for SDH. So on the similar notes, it is going to be seen, and along with that, there is going to be moderate enhancement. So collection with moderate enhancement, multifocal enhancement, it is suggestive of abscess when the patient is having clinical features. So emergency craniotomy and drainage is done, and it has high mortality if it is delayed. So important to know. Tubercular disease, so no fever. So always remember no fever. So there might be two presentations of tuberculosis. One is meningitis. So meningitis might be present in a patient. When tubercular meningitis is present, it is mostly seen in immunocompromised condition. But when the patient is immunocompetent, whenever the patient is immunocompetent, the tuberculoma or abscess might be formed. Because the tubercles are loculated to one region, it is going to restrict that inflammation to that lesion. So tuberculoma might be formed. So whenever you are going to do a lumbar puncture, there might be lymphocytosis. So whenever it is a bacterial meningitis, you are going to see typically what are called as polymorphonuclear cells. But whenever you are going to go for a viral puncture or a tubercular puncture, you are going to see lymphocytes. But what differentiates between virus and tuberculosis is the glucose. So glucose is going to be low in TB because bacteria are going to utilize glucose. Virus don't require glucose. So in viral meningitis, the glucose is going to be normal, and AFB culture might come, but it is slow. Hence, you can go for what is called as ADA, adenine deaminase levels. So whenever the ADA levels are raised, you can suspect a TB and start the patient on empirical AKT. 9 to 12 months of AKT. Dexamethasone is given if the patient is having cerebral edema. And surgical drainage for tuberculoma if the patient is having mass defect. So whenever the patient is having some mass effect, you need to remove that mass. If it is not causing any mass effect, start AKD for 12 months. It might resolve spontaneously. So always remember, brain and glioma, it needs to be differentiated. Both show ring enhancement on contrast CT scan. So whenever you are going to do a CT scan, they are going to show the contrast ring enhancement. But diffusion weighted MRI is the key. Abscess shows restricted diffusion and glioma does not. So it is very important to know that abscess is going to show diffuse restriction, but MRI for glioma is not going to show any type of restriction. And always get it done before labeling anything as a tumor, because a tumor and an abscess has total different prognosis, total different outcomes, and total different management. So it is very important for you to know that whether it is an abscess or whether it is a grade 4 glioma. For that, diffusion restricted MRI. In diffusion restricted MRI, if there is restricted uptake, it is abscess. If it is non-restricted uptake, it is going to be glioma. So now coming to the subarachnoid hemorrhage. So subarachnoid hemorrhage, we have already talked about the traumatic hemorrhages in the trauma. So here what comes is a subarachnoid hemorrhage due to bleeding vessel. So it might be because of aneurysm, it might be because of hypertension. So subarachnoid hemorrhage, so 80% it is because of the ruptured berry aneurysm. So it is a non-traumatic subarachnoid hemorrhage, most commonly seen at the anterior communicating artery. Both are important MCQs. We know that the brain has circle of Willis. So if you know, this goes the MCA. Here the ICA is going to split into ACA. We know that this is ACA, and from here the basilar artery, here goes the posterior cerebral artery, and here it is the posterior communicating artery. Here we know that it is going to be anterior communicating artery. So most common site for the berry aneurysm is going to be this junction. So this is the junction for most common site of berry aneurysm. We know that berry aneurysm might be associated with some congenital conditions. If anybody can recall, it is associated with polycystic kidney disease. So an MCQ is going to come for you that what a patient of polycystic kidney disease goes sudden onset hypertension, sudden onset headache, and patient dies. What is the most common cause of death? So the most common cause of death in polycystic kidney disease is because of rupture of berry aneurysm, which causes subarachnoid hemorrhage. So that is an MCQ which is going to come to your savior in when you are going to give for NEET PG. So there is a posterior communicating artery aneurysm as well. So ACA-MCA territory accounts for 40% of the aneurysms all over together. Sudden onset thunderclap headache, worst headache of life, and it is associated with features of meningism. So what is meningitis versus meningism? So meningism is where there is nuchal rigidity, there is headache, but there is no fever. In meningitis, there is always associated fever. But in meningism, there is no fever. So without fever, if you are going to have that nuchal rigidity and headache, it is considered to be a subarachnoid hemorrhage. There is photophobia, nausea. So 1 in 3 subarachnoid patients are misdiagnosed at first presentation. So they might be misdiagnosed as a tension headache. So you might feel that don't worry, there might be some normal headache, take this crocin tablet and go home. So no, if the patient is coming to you with the complaint of headache, it means that the headache is severe. All the patients are well read. For any type of headache, they first are going to go to the chemist. They are going to go to the local medical shops, and then they are going to seek the tablets. And then if it is not working, then only they are going to come to you. This is the sad situation of our country, but it is true. So the chemist is already given him what is called as the migranil tablet. They have given him diclofenac tablet, they have given him paracetamol tablets, and still it is not working. Then the patient is coming to you. So any patient of headache coming to your OPD, don't just misdiagnose the patient as a tension headache and let him go. A CT scan won't cost you much, but if it is going to save, if it is the actual truth. And why it is important to do a CT scan in time, we are just going to discuss in 2 minutes. So there is a grading system which is called as World Federation of Neurological Society. So they have graded SH into 5 different grades: grade 1 to grade 3, grade 4, grade 4 and grade 5. So we don't need to go in the details. Always remember that grade 1 and grade 2 there is no neurological deficit. In grade 5 the patient is already in the coma. So what happens is grade 3 and grade 4. So in grade 3 and grade 4 the patient is going to have focal deficit. And here the patient might be going into, so it is impending vegetative state. So that's what they have given. In grade 1 and grade 2, the GCS is above 13 always. In grade 3 and grade 4, the GCS deteriorates. And in grade 4, typically, the patient might go into the patient's condition is getting poor and patient is moving towards the comatose state. So this is going to tell you about the outcomes of the patient. So if the patient is going to present in the grade 3 or grade 4 or grade 5, the patient is already almost consider that the patient has almost lost everything what he has. But if the patient is going to come to you within grade 1 and grade 2, it means that the patient's recovery is favorable. So neurologically, prognosis is excellent. Here there is good grade, there is mild headache with neck stiffness only. Here it is moderate grade, focal deficit is present, it is poor grade, and it is poor grade and comatose. So palliation is the only key in when we are dealing with grade 5 subarachnoid hemorrhage, that you should know. What is a MCQ point, which is a Terson syndrome? So whenever the subarachnoid hemorrhage is occurred with vitreous hemorrhage, it might be there in 20% of the patients. It might be because the ICP is raised suddenly. In case of tumor, in case of trauma, the secondary brain injury sets in for at least some amount of time. So there is some time for the brain to compensate. So there is no vitreous hemorrhage seen in cases of trauma. We did not talk about any vitreous hemorrhage seen in trauma. But in non-traumatic SAH, there is associated with vitreous hemorrhage. And that vitreous hemorrhage is nothing but called as a Terson syndrome. So how are you going to diagnose? So always remember, any acute presentation, a CT head is going to have 98% sensitivity. So when you are going to do a CT scan within 6 hours, it is 98% sensitive. But after 6 hours, the sensitivity drops to 85%. Because the blood is going to mix with the CSF and you cannot pick it up on the CT scan, and MRI is going to take time. So CT scan when done in time is going to save the patient's life. So never hesitate for doing a CT scan in conditions of headache. Hope it is clear. When it is a delayed presentation, a lumbar puncture is mandatory. Sir, how to diagnose a patient if the CT scan is normal but patient's features are suggestive of SAH, hypertensive episode, neck stiffness, headache, loss of vision, raised ICB, but I'm not able to get a diagnosis on the CT scan? Sir, how to diagnose? Do a lumbar puncture, and in lumbar puncture, you can find out that the patient might have xanthochromia. The CSF cells are become yellow and there might be some yellow CSF, or there might be active blood in the CSF. Xanthochromia is yellow discoloration of CSF due to oxyhemoglobin and bilirubin. So bilirubin, so the RBCs are going to break down into bilirubin and it is going to peak at 12 hours. So xanthochromia might persist for next 2 weeks. So don't try to do lumbar puncture every day. अरे वाह सर, रोज पीला पानी आ रहा है, सब निकाल देता हूँ एक दिन. No, it is not going to go. So you have to wait till 2 weeks to resolve. It is going to resolve spontaneously. Sir, how to manage SH? So first thing, if it is an aneurysmal bleed, you should consider saving that aneurysm. You should actually prevent the patient from having that aneurysmal rebleed. For that, just see the aneurysm. So if the aneurysm's neck, what are you going to see? The aneurysm neck. So if it is going to be a bottleneck, so when the neck is going to be short, you can go for coiling. But if the neck is wide, then you need to go for clipping. So clipping is an open procedure. It needs to open up the brain. A craniotomy needs to done. So clipping is having more problems, more morbidity and more mortality as compared to the coiling. So whenever feasible, you can go for an endovascular coiling. But if the neck is broad, then coiling cannot be done properly. So if coiling is not done, then you should go for clipping. So you should know when to call an interventional radiologist or when you should call a neurosurgeon. So think of the neck. So coiling is preferred if suitable anatomy, and clipping is done for wide neck aneurysms or if the coiling is going to fail. So coiling, if it is going to fail, then only you can go for what is called as an open clipping. Prevent rebleeding. So the most important thing is, if you have spotted an aneurysm, go straight away and actually think for clipping the aneurysm. If not, it is going to cause rebleeding 70 to 80% of the patients. What happens after bleeding is all the vessels of the brain are going to go into sudden vasoconstriction. Because of the sudden bleed in the CSF, sudden raise in the ICP, all the blood vessels are going to go into sudden contraction. Only seen in SH, not seen in other conditions, not seen in trauma, not seen in other tumors. So sudden, as the pathology is going to happen very suddenly, the brain vessels are going to constrict very suddenly. So there, to prevent that vasoconstriction, because that vasoconstriction will cause more death of the brain tissue. So to prevent that, you are going to give calcium channel blocker, and it is called as nimodipine, and always try to give nimodipine through RT. So they have seen that oral route is preferred always rather than IV, because oral route is, I don't know if it is more absorbed or what. I also need to go and study the details about it. But what have they told? The most important thing is try to give as much as possible when you are going orally. It is going to improve the neurological outcomes. Until how many days you are going to give? You are going to give it for almost 21 days. So here remember that whenever there is going to be SAH, there is going to be SIADH. So SAH, SIADH, they appear to be same. So what is SIADH? The body is going to cause more secretion of ADH. So ADH is going to conserve the water. So because of SAH, what is going to happen? SAH, it is going to cause SIADH, and SIADH will conserve only water. And because the water is going to increase, the sodium is going to be normal, the body will end up into what is called as hypervolumic or euvolumic hyponatremia. So whenever the body is going to have that, sodium is going to be normal, but only the water is going to rise, so it is called as euvolumic hyponatremia. Misnomer hai ye. But the sodium levels are normal, but the water levels are rising. So comparatively, sodium will be less than water. So it is called as euvolumic hyponatremia. So here you can give lots and lots of NS. So there was a question which was asked initially, which IV fluid to prefer. So only and only indication of NS in neurotrauma is always going to be an subarachnoid hemorrhage. Because subarachnoid hemorrhage is going to give rise to what is called as, yes, SIADH. So it causes SIADH, it causes hyponatremia. So do not restrict the fluids. Hyponatremia can worsen the vasospasm. Hence sodium needs to be corrected, and hence NS is the fluid of choice in resuscitation. The vasospasm, it can be a cause of delayed neurological deterioration. So always maintain the patient with adequate, you can say the patient should be having adequate volume, and also you can give vasopressors to the patient to get up the BP. Consider intra-arterial nimodipine or balloon angioplasty. So whenever the patient's vessels go into constriction and it is not recovering, then what they do is they go for intra-arterial nimodipine or balloon angioplasty. So it is again a very high grade and tertiary care procedure, but at least you should know that if nimodipine tablet fails, what is the next line of management? If there is a neurological deterioration, exclude the rebleeding, or there might be communicating hydrocephalus. We saw that if the patient's condition deteriorates on day 3, day 4, day 5, we saw something called as secondary or communicating hydrocephalus. So what happens in communicating hydrocephalus? All the bleeding is going to go in the subarachnoid region, and it is going to cause the it is going to coagulate the cisterns, and there is not going to be any absorption of the CSF, so it is going to cause communicating type of hydrocephalus. So urgent CT is to be done, and if hydrocephalus is there, we saw that it is an acute condition, so in acute condition it is EVD. In chronic condition you are going to put ventriculoperitoneal shunt. If it is a permanent thing or a palliative procedure, you can do a third ventriculostomy in the patient, endoscopic third ventriculostomy. BP management, prevent the rebleeding, it is very much important, and always lower BP if mean arterial pressure is more than 130. So mean arterial pressure is nothing but diastolic pressure plus 1/3 pulse pressure. So if the mean arterial pressure is going to be more than 130, which is highly hypertensive, the systolic blood pressure here almost might be reaching 200. So it might be something like 200 by 120 mm of Hg. So whenever this type of BP is there, always try to lower the BP. Always try to lower the BP. But never ever let the patient go into hypotension. So never ever let the patient go into hypotension, because if it is hypotensive, we have seen that the cerebral perfusion pressure is hampered. So it is very much important to balance the actual blood pressure of the patient. Along with that, you need to manage the patient's, you need to manage the patient's hypertensive episode as well. So these are few conditions which are again just factual things. You should just go through them because they are predominantly asked in the NEET PG and they are given in the Bailey Love. So I have included them in my notes as well. So spontaneous intracranial hemorrhage. So there is no aneurysm, there is nothing, but the patient has intracranial bleed. It might be because of hypertension. So most common cause is hypertension, or there might be something called as vasculitis, some problem with the pathology. So might be causing some amyloid angioneuropathy. Nothing to worry. Here the mortality is very high, and always remember target MAP less than 130. So in trauma we saw that don't go for hypotension, but when it is related to aneurysm rupture, always you are going to maintain the blood pressure on a lower side, but never go for a permissive hypotension here. What is an arteriovenous malformation? You have seen typically, which is called as a whenever the child is born, whenever there is some abnormal communication between artery and vein, it is called as AVM, which is arteriovenous malformation. So AVM might be present, and that AVM is nothing but a vein of Galen malformation. So here this typical photo is given in your NEET PG, and they have told you that yes, this is the vein of Galen malformation. How are you going to approach this patient? So this is nothing but a vein of Galen malformation. So this vein of Galen malformation, you can go for a radiosurgery or an embolization. What happens is, because of this vein of Galen malformation, the cerebellum is not well developed. As you can see, the cerebellum is hypoplastic, and along with that, the patient has high output cardiac failure. High output cardiac failure is present in the patient because the artery is directly communicating with the vein, so no pressure system between them, so blood flows rapidly in the system, so it causes high pressure cardiac failure. If the arteriovenous malformation comes later on in life because of trauma, there might be an acquired fistula. It might be caused because of thrombosis of the venous sinuses. So here you can again go for embolization. So embolization in vein of Galen malformation, in cases of acquired AVM, acquired arteriovenous malformation, embolization is the first surgery. If not, then you can go for a resection. Very much important. So what important three things we discussed: spontaneous intracranial hemorrhage, no other comorbidities except hypertension, then arteriovenous malformation, which is at the birth, which is a vein of Galen malformation, go for a microsurgery, or you can go for an embolization. Here you can also go for what is called as a Spitzer-Martin grading. So this is a grading which is not important right now, very complex neurosurgical topic, but this grading name might come to you in your exams. If it is an acquired malformation, you are going to go for embolization. If it is a cavernoma is nothing but, see, there is a proliferation of blood vessels. It is very highly vascular tumor and it causes rapid deterioration of the symptoms. So Mulberry-like lesion, and it can be seen either occult on angiography or visible on MRI, and conservative if asymptomatic, and surgical excision if it is symptomatic. It can cause seizures or it can cause hemorrhage. So if it is symptomatic, then you need to go for a surgery. If there is a carotid artery disease, so always remember, in 99% of the stroke patients, the problem is with the carotid arteries and not with the heart. So whenever you are going to do a carotid Doppler, you can find atherosclerotic plaques in the carotid artery. So whenever the atherosclerosis is causing complications like transient ischemic attacks, you can go for what is called as end arterectomy. So what is end arterectomy? Open the carotid artery and remove the plaques and again suture the artery. So what that is called as carotid end arterectomy. So you can go for carotid end arterectomy. So when the stenosis is more than 70%, you can go for carotid end arterectomy within 2 weeks. So if you have an episode of transient ischemic attack, we know that the brain's problem has been divided into two types. One is the transient ischemic attack and another is a stroke. So stroke is actually full blown, which has a permanent neurological deficit, and transient ischemic attack is something wherein the attack has just come and within 24 hours there is complete recovery of the brain. So when the patient is in transient ischemic attack, you do a carotid Doppler or carotid angiography, you find out that there is atheromatous plaque in the carotid, you can go for a carotid endarterectomy and you can straight away do the suturing of the carotid artery again, and there is almost benefit, class 1 evidence that it is going to present, that it is going to relieve the patient risk, but there is no proven benefit. For example, a patient is doing a routine investigation and the plaques are found in the carotid artery. So is it going to help? So no, there is no role in asymptomatic patients. If the patient becomes symptomatic, then you should go for a carotid endarterectomy. So it is very much important. Very much important. There is no role of stenting. The stenting is always inferior to carotid endarterectomy. So whenever it comes to for carotids, endarterectomy is always preferred. Whenever for carotids, endarterectomy is always preferred. So I hope it is very much clear. So just to tell you an example, when I was doing my UG, so I got a chance to actually see a case of cavernous sinus hemangioma. So that case lasted for almost 12 to 14 hours. The cavernous sinus itself is a vascular structure, and there was formation of this type of hemangioma inside the cavernous sinus. So you can imagine how much amount of delicate surgery it would have been. So almost 12 to 14 hours the patient was in the operative theater, and we were playing near the carotid artery, near the cavernous sinus. So very much kind of a meticulous surgery done at the skull base at a very, the location is very much tricky to handle with. So these are the complex surgeries which go on in neurosurgery. So if you are very much willing to go for that microsurgery and that fine skill, neurosurgery is waiting for you. So I hope the topic is very much clear. So tomorrow we will go down with the brain tumors, and then we will start off with what is called as neck anatomy, head and neck anatomy. So that is all which is clear. Tomorrow is Sunday, so we'll take a break tomorrow. We'll start again on Monday. So if you have any doubts, you can post it on WhatsApp or you can post it on Instagram. I'll be more than happy to help. Till then, thanks for attending the lecture. Take care, bye bye, and good night.